We're live.
Uh, Good afternoon, all, and welcome for today webinar about prioritizing breastfeeding, creating sustainable support system. This is We are on course with World Breastfeeding Week, and today's presentation has a theme uh, about how to prioritize breastfeeding and then how to create a sustainable support system. So for today's presenter is Virginia Wanjiku. Is a registered nutritionist stroke dietitian working at Kenyatta National Hospital. He has an experience in the field of breastfeeding and also pediatric nutrition. Welcome, Virginia.
Thank you, members. We are going to have a discussion today about World Breastfeeding Week, and I hope we'll be able to interact to be able to see how we celebrate the World Breastfeeding Week. So, as you have been told, my name is Virginia Wanjiku, who will be taking you through this particular discussion. So, this year's World Breastfeeding Week, we have our theme, prioritize breastfeeding, create sustainable support system. And that is the theme of the week that we are championing for this week. It's a global campaign to raise awareness and galvanize action on themes related to breastfeeding. Anything related to breastfeeding is here. Thank you. So we'll start with the evolution of the World Breastfeeding Week campaign. This World Breastfeeding Week is celebrated every year from 1st to 7th August in commemoration of the 1990 Innocent Declaration. That means that it is a week that is there to support breastfeeding. The declaration came about in trying to make sure that every person on earth worldwide is able to celebrate breastfeeding, is able to assist all mothers to be able to breastfeed their babies. So in a World Health Assembly, which sat in Italy, in Innocenti, it was declared that we'll be celebrating the World Breastfeeding Week. It officially started in 1992 with several themes through the years. We have had several themes throughout the years. And each year, as the themes are running, we are able to actualize and we are able to anchor and galvanize the actions for that particular year as we have run around. So what themes have we had? We've had themes about talking about the healthcare systems. We have had themes about women and work. We have had themes about international code of breast milk, marketing of breast milk substitute. We have had themes on community support. We have had themes on ecology, science, education, and human rights. We have also had discussion on workplace support for women. And all these, among others, have been able to allow us to be able to align ourselves to the Sustainable Development Goals that started in 2016. It has been very fruitful throughout the years. In 2018, the World Health Assembly again endorsed the World Breastfeeding Week as an important breastfeeding promotion strategy. We had several strategies along the years from 1990, but in 2018, it was said that this is an important way of promoting breastfeeding. And it's one of the strategies that we embraced as Kenya. Kenya being a member of that assembly that sits every year, they adopted the strategy, and that means every year Kenya is able to, sorry, I have a cold. Kenya is able to celebrate this year and be able to talk widely and discuss widely with the population at large about breastfeeding and be able to sustain it. It's a way of promoting, protecting, and supporting breastfeeding as a norm for our mothers and their babies. So the theme for this year, as we have said, is prioritize breastfeeding, create sustainable support system. And we're going to see how KNH as a hospital is doing their bit in creating sustainable support system for mothers and babies who happen to be our clients at the hospital. So what are the objectives of this year's World Breastfeeding Week? The first one is inform. And when we're informing, this means that we need to inform people about their role in creating supportive and sustainable environments for breastfeeding. Because if we don't inform them, how then will they be able to articulate matters breastfeeding within the hospital and outside in the communities? Number two, one of the objectives is anchor continuous breastfeeding support as a vital component to create a sustainable environment. That means for every activity that runs through our maternal and infant child care, we're going to anchor breastfeeding and make it a norm to be able to ensure that our mothers have an environment that is sustainable for them to ensure that they are breastfeeding their infants and babies. Number three, we need to engage with individuals and organizations to enhance collaboration and support for breastfeeding. At the hospital, the different departments are called upon to be able to ensure that they engage with each other. We have the nutritionists, we have the nurses, we have the doctors, we have the physiotherapists, occupational therapists, all of them, plus any outside organization that supports KNH. We need to ensure that we have these discussions to ensure that we support breastfeeding. We'll also be able to engage with the mothers and also their families about ensuring that breastfeeding is very well supported. Objective 4 on galvanize. Galvanize action on connecting breastfeeding support system to contribute to a more sustainable environment. We have to make sure, kutia moto, we make sure that this action, any action that is required of us as a hospital, we are going to ensure that we support and promote and protect breastfeeding as our norm. So we're going to look at the actions that are required for us, or the actions that we are proposing to do as we go along, even after this week is over. So we are going to go by objective, and our objective number 1 is inform people about their role in creating supportive and sustainable environments for breastfeeding. So KNH, we are going to have sensitization meetings on the 10 steps to successful breastfeeding. Within the hospital, all the areas that have mother and child, we have sensitization meetings going on all the way from first, and they'll continue all the way to date 7. And each morning we have sensitization within our different workstation. Then we're going to create public awareness campaigns. We'll have our members going to TV to be able to have a TV show. We already have one TV show that happened. Our head of department was able to represent us at one of the radio stations last week, and we are still continuing. We have some of our colleagues going for radio shows to be able to talk and articulate matters breastfeeding. We have the social media handles. We already have photos on our Facebook, Twitter, and all other media. We have flyers that are going around within the hospitals so that every person within the hospital knows what is this that we are doing to create awareness campaigns. The other programs are still running in terms of creating public awareness campaign. We are part of the national team as KNH. We have made sure that we are part of this agenda of ensuring that we are supporting breastfeeding. And the team is wide. We're also going to have a webinar. This is the webinar we are having today. And there are others that are within the hospital, highlighting the link between breastfeeding and sustainability. We already had a continuous nutrition CNE education that happened last week, where we also had discussion between the different stakeholders that take care of the mothers and children. From there, we have arranged a high-level meeting with the policy makers and the leaders within KNH to be able to let them know what is expected of us as we support, promote, and protect breastfeeding, so that they can also be able to ensure that we are creating this supportive environment for that. Objective number 2, as KNH, we are going to be able to anchor continuous breastfeeding support as a vital component to create a sustainable environment and foster sustainability of this. So what do we intend to do? We are going to ensure that the hospital launches the World Breastfeeding Week to sensitize the community. And we have done that through the ways I've said. We have the radio, we have the TV, we have the sensitizations within our service areas that are going on. And number 2, we're going to strengthen baby-friendly hospital facility initiative with climate-conscious messages. I'll discuss the 10 steps to ensure that the hospital is becoming baby-friendly. And it's our goal to ensure that our hospital is baby-friendly. We were designated before as baby-friendly because we had adhered to the 10th step of successful breastfeeding, but we are taking extra action to ensure that we are not left behind and our hospital is becoming baby-friendly. We're also going to ensure stakeholder engagement on long-term eco-sustainable breastfeeding interventions. And those stakeholders and engagements are already ongoing within the hospital. Each stakeholder that takes action in ensuring that we protect, promote, and support breastfeeding is engaged at this particular in this particular week. Also, in terms of anchoring, we have a lactation room in the nutrition department. That means that our staff that are breastfeeding are able to be supported to be able to go and express their breast milk. It's not possible to have our staff coming with their babies to hospitals for them to be able to lactate. And for that, the hospital was able to provide a lactation room within the department so that all the staff that have babies, they can be able to come after they are through with their maternity leave. They can be able to continue lactation by ensuring that they can express in that room. It is a well prepared room that is able to support those mothers. Also in anchoring, we'll have discussions involving environmental groups, nutritionists, and healthcare workers to explore the climate breastfeeding link. We have to be able to link within the different departments, within the different stakeholders in the hospital to ensure that we are not breaking that link. Sorry. Okay. We're on objective number 3, where we're talking about engagement. So we're going to engage with individuals and organizations to enhance collaboration and support for breastfeeding. For that, we'll have a roundtable discussion with key actors in KNH. Those are the ones in management and the policymakers within KNH. And this discussion will revolve around how do we support, promote, and protect breastfeeding within the institution, because we're supposed to come up with policies, especially the Breast Milk Substitute Act policy, to be able to protect our babies from being given or being provided for breast milk substitute. We're also going to see how the different policies that surround breastfeeding are enacted within KNH. We're also going to include green practices in workplace breastfeeding support programs, and that those will be discussed within that roundtable discussion. We'll have conversations with youth, people with disabilities, and vulnerable groups on breastfeeding and the planet. And those discussions will be articulated to ensure that the youth understand, since they are the people who are bearing children, we'll be able to discuss with them. The people with disability who may have a few issues here and there in sustaining breastfeeding, we'll also be able to have a discussion with them, the ones that are within our proximities. The vulnerable groups also will be able to have discussions with them. We are going to have a walk, yes, to be able to see just within the hospital, we'll be able to have a breastfeeding walk so that we can create awareness about breastfeeding. We'll have employer engagement fora to promote workplace breastfeeding policies, sustainable practices, and strengthen maternity protection. Currently, the hospital gives our staff that have given birth their full maternity leave, and we also have the annual leave in addition to the maternity leave. And we are going to see how that can be kept at par to be able to ensure that we also have the hours that are allowed by law to be able to allow our mothers to be able to express their milk, and also have flexi hours so that they can be able to get home early and breastfeed their babies. We'll have green pledges for organizations to commit to supporting breastfeeding friendly and an eco-conscious environment. For everybody who interacts with us, we are going to have the pledges for them to be able to support us in every way. In Galvanize, we're going to galvanize action to connect breastfeeding support systems to the broader sustainability and climate agenda. And what are we going to do? We're going to have policy dialogues linking breastfeeding promotion with national climate strategies. For example, the Kenya Climate Smart Agriculture Strategy, to see how they can be able to link with us to be able to promote breastfeeding. We are going to engage the spouses, the family members, and friends of mothers who visit our facility to orient them to skills for them to be able to support women to breastfeed, including the ones that are here. And once they go home, the mothers that leave our facility, they'll be able to be supported wherever they are, to be able to ensure that even if they go to work, are their workplaces able to support them to sustain breastfeeding exclusively, especially for the first 6 months of life. So we are going to have that discussion to be able to have that. So why are we really concerned about breastfeeding? Why are we talking about exclusive breastfeeding? Why is it that we need to sustain breastfeeding continuously? And we have this theme that is World Breastfeeding Week. Number one is that we have a global strategy on infant and young child feeding to revitalize the world's attention on impact of feeding practices on their nutrition status, growth and development, health, survival of infants and young children. It is not just a by the way. Breastfeeding has its benefits, and that is why we need to be able to look at why it is important. As the global sat in the Innocenti Declaration, and there were more discussions before that, and as the world sat in the assemblies, the first thing that came up is that we have 4 global recommendations, and we are looking at the first one in this particular agenda. It is the one that starts in that we should have immediate initiation of breastfeeding within the first hour of birth. Immediately as child is born, the child should be initiated to breastfeeding within that particular 1 hour. Even if there are issues, a child may be born through cesarean section, there may be a lag, but within the first 1 hour of life, a child should be initiated to breastfeeding. We should have skin-to-skin contact still within that. We should have skin-to-skin contact with between the mother and the child immediately they are born. We don't put the children in incubators. We don't put children away from the mother, wrapping them. We don't take weight immediately a child is born. The child should be placed on the breast immediately. skin-to-skin contact, and then the breastfeeding itself will start within the first 1 hour of birth. Recommendation number 2 from the global strategy is that we should have exclusive breastfeeding for the first 6 months of life. There's no mixed feeding. We are not giving anything else unless it is medically indicated. So we are going to be able to sustain that as a part of the theme for this year. Recommendation number 3, we should have sustained breastfeeding for 2 years or beyond, alongside appropriate, adequate, and safe complementary feeding from 6 months of age. We should not give our children anything before 6 months, and what we should give at 6 months should be able to complement our breastfeeding, and we should be able to sustain breastfeeding with the additional complementary feeding from 6 months all the way to 2 years and or beyond. Number 4 recommendation, we should have optimal maternal nutrition, social and community support. So immediately a mother realizes she's pregnant, the mother should have optimal maternal nutrition that should be given at the antenatal clinic, where they are given all the information that they need to be able to ensure that they are healthy nutritionally. We urge the community at large, starting with the family, so that we can be able to give these mothers social support and community support within the environment where they come from. And we take through that by discharging our patients from here, our clients, our mothers who have given birth. We recommend that they go to be continue to be supported within their community setup, nearest community health center or nearest health facility that they have. Also, by ensuring that anybody who is within their care is able to support them. So those are the 4 recommendations which KNH already is doing every way possible to be able to actualize them, or to be able to ensure that we are handling them and ensure that we promote, support, and protect breastfeeding. So we're going to look at the policies, the breastfeeding policies that are there in Kenya. That shows that once we adapted the 4 recommendations, Kenya also has within its governing structures ways of protecting the mother and child in ensuring that they have good nutrition. And the first one is the Kenyan Constitution 2010, which directs that all children, in one of the articles, all children should be able to have good nutrition. And that one we adhere to, and we need to ensure that as KNH, we are able to ensure that every child who passes through KNH is able to achieve that. We have the Employment Act 2007, which says our mothers should be given maternity leave for 3 months full, and then after they get their maternity leave for 3 months, then they can be able to take their leave, their annual leave after that. So mostly we have an added around 1 month of a mother, she can stay home, so that by the time she's coming back to work, she's able to have breastfed the child or the baby for at least 4 months, ideally. Then the mother can be supported with workplace support so that the child gets to 6 months of exclusive breastfeeding. We have the Health Act number 21 of 2017, which supports also the issue of breastfeeding. We have the Maternal, Infant and Young Child Nutrition Policy Summary Statement of 2019, which has everything that pertains to breastfeeding. How do we support, protect, and support breastfeeding? It's all articulated in the MIYCN Policy Summary Statement. It has 19 action points, with the 20th one being we support mothers who are HIV positive in ensuring that their babies do not get infected by the virus, and they are supported to breastfeed their babies up to 2 years and beyond. We also have the Breast Milk Substitute and Regulation and Control Act, which was enacted in 2012, which states that our children should not be given a breast milk substitute at any time unless it is medically indicated. This Breast Milk Substitute Act has indicated what items or what are these breast milk substitute. They are well articulated, starting with the formula. We have the teats and pacifiers. We have breast milk, what are they called? Fortifiers, they are also there. We have we have different ages for the breast milk substitute, and for either of the ages, either up to 6 months or after 6 months, we should not give any of those. So our child is supposed to be exclusively breastfed for 6 months, and when complementary time comes in, we should not be able to give any substitute, any of them. Even we have items that are complementary feeds that purport to be feeds for children. Also, those ones come under the designated products for breast milk substitute. We should not give our babies those, and that is anchored in the Breast Milk Substitute Act. We realized, or Kenya realized, that this act was not enacted very well, and there were regulations that came in 2021, which are the Breast Milk Substitute Regulation and Control General. How are we able to enforce these regulations that were put in 2012? And so we have a regulation and control 2021 Act to see how we look for them. We look for the Breast Milk Substitute Act and all and anything that the child is not supposed to take. For KNH, we have ensured that only the children who require or who have medical indication to be able to be given a substitute are given. We rarely give a breast milk substitute unless it is medically indicated, and we are very careful on that. So for us to be able to know why, or look at the reasons why Kenya is coming up with this World Breastfeeding Week, we have to look at data. We have looked at what KNH is going to do or championing to do to be able to promote, protect, and support breastfeeding. Why are we doing all those? Why are we going with the 4 objectives? First of all, we look at the Kenyan data. We usually do surveys because data talks, data speaks. Without data, I wouldn't know why we are doing what we are doing, and we wouldn't be championing the different strategies every year to be able to improve our data. So we are going to look at this data. It's national data. KNH is able to deliver babies that add up to this data nationally. So we are going to look at it. So the first one is early initiation of breastfeeding within 1 hour of birth. And this is the Kenya Demographic Health Survey, the 2022 one. What does it show? These are the percentages of babies or infants that are initiated to breastfeeding within 1 hour of delivery. So we have different categories of mothers. So for the mothers who had a vaginal birth, 65% of them were initiated to breastfeeding within 1 hour of delivery. For mothers who had a cesarean section, 34% were able to be initiated within 1 hour. There's usually an issue when a mother has to go through cesarean section because they have to recover from the drugs that are given during the cesarean section. We have a category of mothers of infant in rural areas, and for these mothers, 63% of them were able to initiate their babies within the 1st hour of birth. We have mothers who are in urban centers or in urban areas. They're able to initiate their babies within 55, at least 55% of them were able to initiate their babies within 1 hour. There is a disparity between the ones who give birth in rural areas and the one who give birth in urban areas. We need to look at why that disparity, what happens for these mothers, so that we can be able to raise up our data and be able to look at, do we need to put more effort to the urban mothers? What do we need to do to raise our data? We are still lower. We are still lower than 70, lower than 80%. We are actually at 65 for the vaginal birth and 63 in rural areas. What do we need to do to improve this data? This is the early initiation for breastfeeding within 1 hour of delivery across the counties in Kenya. We have Vihiga County that was leading at 87.2% of all mothers were initiated within 1 hour of delivery, with the list being Kisumu at 21.5%, and the graph is talking for all the 47 counties. Overall, we had a 60.1% of all births of babies who were initiated to breastfeeding within 1 hour. So an average of 60.1, that is low because we should aim for a higher one. This graph it shows exclusive breastfeeding by age. Looking at the graph, it has a color scheme. We have the full blue for 0 to 1 month. The ones that got exclusive breastfeeding, most of them got, that is going up to around 60-something%. We are not yet at 80. We were going at close to around 70. We have between 2 to 3 months, the rate goes declining, so that by the time we are 4 to 5 months, we are only at about 40% or less of exclusive breastfeeding. Something happens between the 2nd and the 3rd month. And for all categories, they reduce. But the category that is increasing is the one for breast milk and or semi-solid or soft food. And we can see it starts about 2 to 3 months. We have the children being introduced to other feeds, or we have mixed feeding at that particular time. That means that something needs to be done. And this coincides with the time the maternity leave is ending, our 3rd month. By the 3rd month, our mothers are already leaving the homesteads to go to work. And that is what we can be able to tell from this particular graph. It is not a good picture for a country that is trying to support breastfeeding all the way to 2 years, in addition to complementary feeding at 6 months. So something needs to be done so that our data remain above 80 for exclusive breastfeeding all the way to 6 months, and reduce this mixed feeding that our children are getting as the age continues. So these are breastfeeding indicators. Data is still talking to us. This shows the percentage of the preference of the different indicators of breastfeeding that are relevant to us. We have 2 color schemes. The one in blue shows the KDHS 2014, the data that we had collected in 2014. And the one in orange is the KDHS 2022. So we are doing comparison within the 2 demographic health surveys. So the first one is initiation of breastfeeding within the first 1 hour. We can see in 2014, we had 62%. In 2022, we declined. We are at 60%. That means we are not initiating breastfeeding within the first 1 hour. Something is going on. We need to find out why, because we should have increased, but then we actually went down. The next indicator, exclusive breastfeeding below 6 months. And in 2014, we are at 61. In 2022, we are at 60%. That means also we went down a digit in terms of the prevalence. And that shows that, as we have looked at the data before, the previous slide, we are not improving. We are doing mixed feeding, and the rate of mixed feeding is going higher than the one for exclusive breastfeeding, dropping our data with a digit. Looking at the next one, exclusive breastfeeding, 0 to 1 month. This was the first time we were collecting this data, and it reads in 2022, the data shows 77% in terms of prevalence. And that, I think, as we have seen from the data, that is the graph that has showed us we were actually at 77. We move on to the indicator of exclusive breastfeeding at 4 to 5 months. In 2014, we were at 42%. In 2022, we were at 38%. So within the 4th and 5th month, the data really went down. And as we saw, that is where mixed feeding was rising. Continued breastfeeding at 12 to 23 months, where we have introduced complementary feeding. In 2014, we were at 75%. In 2022, we are at 65%. That shows a reduction of 10 points in terms of prevalence. That is also a show that we are not doing well. We have the data on children or infants who have ever been breastfed. In 2014, we had 99%. In 2022, we dropped down to 98%. That means you also have a one-digit drop within the two, between the two health services. The indicator on breastfeeding, 0 to 23 months. In 2014, it was at 22%. In 2022, we were at 34%. And we can see that the data on breastfeeding, on bottle feeding, which is a breast milk, one of the designated products that are breast milk substitute, the data is actually going high. It just shows that our babies are not being breastfed. Our children are being given, either is it express breast milk or the other breast milk substitute that they are getting through the bottles. And that is alarming, that is worrying. Why our babies not being given the breast? We need to ask ourselves those questions as we anchor in World Breastfeeding Week, where we aim to promote, support, and protect breastfeeding. As we continue with data, this is the data talking about breastfeeding and bottle feeding, the urban versus the rural areas. So the mothers in the rural areas, they were breastfeeding. We are at about 69%. And the ones in urban, their continuation is actually very low. I do not know why. We are at around 59%. So you can see more rural mothers are breastfeeding other than the over the urban mothers. What is happening with the urban mothers? What challenges are they having that we can be able to alleviate? We need to be able to think about that. And we also want to see the correlation, because we have the rural mothers using bottles with teat. Their percentage is about 31, about 31% there. They're using bottles with teat. But when we come to the urban mothers, for their use of bottles and teat, it goes high to about 37, 38%. And we can see the rate of breastfeeding for the urban mother is lower, and also their use of a bottle and a teat is actually higher than the ones for rural. So we see where we need to be able to invest. Even as we get our clients as a country and also as KNH, we need to be able to look at where do our mothers come from? What are their influences? What challenges are they having? What support do they require from us as we take care of them to be able to ensure that they are both breastfeeding their babies as is required or as is recommended? Data has spoken. And I'm going to look at why breastfeeding matters. Why are you talking about this breastfeeding? Why are we looking at that data? What is it telling us? It has already told us something, that we have some gaps. Ideally, we're supposed to be, all our babies are supposed to be breastfed. And we can see our data is 60% and below. We need to raise it, at least get to 80%. So why does breastfeeding matter? We have the advantages of breastfeeding. The breast milk itself has perfect nutrients for the child to be able to grow well. It is easily digested and used very efficiently. We have no extra waste product for the baby. The baby is able to digest it without any issues. Their gut is ready to be able to digest breast milk because that is what it is for. The gut of the child is not made to handle cow milk or any other animal milk for that matter. It becomes harder for them to digest. So breast milk is easily digested and used efficiently. It protects the child against, or the infant against infection. It has immune factors that are able to ensure that the baby is protected against infections. Ideally, it costs less than artificial feeding because there's no cost related to it. All a mother has to do is give the baby the breast, and there's no cost involved in that. Breastfeeding itself, the act of breastfeeding, helps in brain and motor development for the child. There are several brain and motor developments that are required for the child to be able to breastfeed. The mouth, the oral cavities, the throat, the whole system, the face has to be able to involve when the child is breastfeeding. The brain is active also. So the whole act of breastfeeding helps in brain and motor development. For the mother, it helps delay a new pregnancy. And the mother who is breastfeeding, we have what we call LAMP, where the mother is not able to get another pregnancy if she's breastfeeding exclusively. And there's a way we are able to tell and help a mother. If she's not breastfeeding exclusively, the likelihood of getting pregnant is very easy. So we always advise our mothers breastfeed exclusively to be able to enjoy this particular benefit. It protects the mother's health, and the mother's health come in many ways, including prevention of breast cancer, and among many others. Prevention of diabetes, because the mother will be able to lose the weight that she gained in pregnancy with ease. So the risk of getting, let's say, diabetes and other health issues may not be likely. So it gathers very many benefits for the mother. The whole act of breastfeeding also enhances the creation of a bond between the mother and the child. The bond created between a mother and her child is so strong that it's rare to be able to break that bond. Everybody is always looking for their mother, and most of the people are able to do that. Breast milk is also able to confer cognitive development, the factors that are there for the brain of the child, raise the IQ to very high. The breastfeed children do not struggle with learning anything. Their cognitive level is actually very high. So it is very key for mothers to ensure that they are breastfeeding their baby as is required within the full recommendation to be able to confer all these benefits of breast milk itself and the act of breastfeeding. And you can see there the mother smiling to her child. So we have evidence of breastfeeding, what it does, part of the advantages. Optimal breastfeeding practices have the potential to save about 4,195 children's lives annually, an important contribution to reducing the under 5 child mortality. I know within the hospital, one of our objectives is to ensure that we reduce under 5 child mortality, child and infant mortality throughout the areas that take care of the children and adults. And so those will be among the children who are saved by ensuring that they are getting breast milk. Also breastfeeding. If one is breastfeeding optimally, we're able to prevent 274 maternal deaths annually from breast and ovarian cancer and type 2 diabetes. It's also saved about 8.9 US dollars, 8.9 million US dollars in annual health system treatment costs related to inadequate breastfeeding. We also have the costs within the Kenyan context, which were taken care of, and the mathematics was done also for Kenya in a survey that was done that is called the cost of not breastfeeding. And it also articulated that we're able to save enough millions for Kenya if our mothers are able to breastfeed their children adequately. Breastfeeding is also able to prevent the loss of about 1.5 IQ points in children each year. So if our children are able to be bright, then we have really major benefits for our children. Evidence also tells us that it reduces families' out-of-pocket costs to treat childhood illnesses. We know the childhood illnesses that are always plaguing our children, mainly the things like pneumonia. We also have otitis media, the ENT infections. We also have diarrhea that plagues our children. We are able to reduce the bills for our families because our children who are breastfed do not end up getting these illnesses. It's also saved families some 622.8 million US dollars that is collectively spent on commercial milk formula each year. So if you can give our babies breast milk, then we can build a case for ensuring that as they're getting it, we are saving ourselves those number of millions, because those are many millions. And probably mothers are not even able to afford this particular commercial milk formulas each year. So we champion for breastfeeding. Wow. What would be the dangers of giving our children or our infants anything apart from breastfeeding? Why would we be giving our children mixed feeding? And we saw our data talking. We have quite a number of our babies from 2 to 3 months. They're starting getting mixed feed. What do we expect? We can see a photo there, a child who have started being given infant formula, another one has been given porridge, another one has been given the particular items they are getting using teats and bottles and cups with spouts. Some of our children are given pacifiers to be able to suck on them at home so that they don't cry, for the mothers to, some of them agitate the mother, so they are given pacifiers. Some are given other things, herbs, water with sugar and salt. Popo is usually the first one our mothers give. I don't know, to clear the tummy or the baby is hungry. That is what they are given. Look at that child. The child was born healthy. Then at the end, by 2-3 months, our child is getting malnourished. By the time they are 6 months, we have those. So what does this mixed feeding do? It interferes with bonding between the mother and the infant, and also with the whole family. The child gets more frequent and persistent infections, diarrhea, respiratory infection, any of those, pneumonia comes to me, ear and throat infection, otitis media, and those ones. Really something that a child can be able to, it can be avoided for a child to get those particular conditions. The child is at risk of malnutrition. If they are given the breast milk substitute, the milk formulas, they are at risk of getting more allergies and milk intolerances. Nowadays, we are seeing more children with eczema. Why? Because they initiated into the milk products at an early age. We have an increased risk of chronic diseases starting with obesity, hypertension later, because for a child who has been mixed fed, they'll either get severe acute malnutrition or they get to the obese, on the obese side, where they'll have the other excess weight related diseases. Also, what happens? A child may get lower scores on intelligence tests. And we don't want our children not to be able to achieve their full potential. We need to ensure that their brain function is up to par. It's actually above normal. The world is moving so fast. We need to have intelligent babies, and so that they can grow into intelligent adults. Also, the mothers may become pregnant much sooner than is expected. Also, part of the dangers is increased risk of anemia, ovarian and breast cancer for mothers. So we need to be able to ensure that, looking at the dangers, we don't need to put our mothers and our children or our infants into those particular risks. Breastfeeding is a vital public health intervention with a powerful climate action tool. And we are going to look at the tool. How are we able to ensure that we are using breastfeeding to be able to ensure that we have a healthy nation, that we have a healthy community? So we have an action tool to ensuring that the environment that we are in, the climate that we are in, we are able to utilize it and make sure that we are prioritizing and supporting that environment to reduce the growing climate impact of artificial infant feed supply chain. Currently, we have a lot of interference for breastfeeding for our mothers and children. Why? We have artificial feeding that is being marketed everywhere within the supply chain. Everywhere you look, a breast milk substitute is being marketed or sold or being prepared. So we are going to look at what are these actions that we need to do through a chain. So for this, for the chain, what do we need to look at? When infants are not breastfed, they receive alternative feeds. For example, the formulas, either as fortifiers or as milk below 6 months or milk after 6 months. There are pollutants generated across the formula production pathway. Because when a commercial breast milk formula is being manufactured, the industries that take action, or the companies that produce the breast milk substitute, there are many activities that happen there, and most of which pollutes our environment. And how do they pollute our environment. The processing, the way they process the products from the time they start, the cooling of those products within the factories, also the storage, how do they store those particular products, the separation of the milk from the cows into skimmed milk. We also have the way they homogenize it, the pasteurization, the evaporation, the mixing, the spray drying, and further cooling. All that is able to pollute the environment that we have. We also have production of packaging materials. We have different packaging materials, which are, we have the aluminum that takes care of the tins. Some are packaged in plastic materials that have that are damaging to the environment. You cannot downgrade them. They are not biodegradable. We also have the fuel for transport and distribution of these products. Imagine they're produced in the Western world, and they have to be transported and distributed within the other countries. And coming to Kenya, you can imagine it being prepared in German and it's landing in Kenya. That's a whole transport. That's a distribution web. All that, the cartons, all those are able to pollute our environment. So we need to be able to see how to manage and ensure that our environment is clean. The water, the fuel, the cleaning agents for daily household preparation and use. Imagine how much water the mother has to use, because the mother has to clean all the equipment that are used to prepare that. From the factory, they use water for that, for cooling and all that and processing. Then come to the household where the mother has to use. There is water to be utilized. Some mothers don't even have clean, safe water to be able to prepare these particular formulas. We also have fuel that the mother will incur. For Kenya, the gas is literally expensive. The one in rural, they use firewood. Some within the different regions, we have the charcoal, which is also is able to be a pollutant. The cleaning agent, remember the soaps, the different types of soap that we have to use to be able to clean those agents. Those are all pollutants. The preparation and use of these formulas creates pollution within our environment. The processing the sugars, the oils, and other additives to the powdered milk formula, because we have different types of milk powders, the powdered ones. We have different types. So things are added into them that are definitely not good for the babies and will interfere with the growth and development for our children. So these industries that are producing these formulas for our babies, the increase in exploitation of our scarce natural resources, that is the land, the fuel, the energy, and the water, from the point of manufacture to the point of use in our current state. So we need to be able to mitigate those and be able to give our babies exclusively their mother's milk. We need to support, promote, and protect breastfeeding. So for the industries also, how do they market? How do they make sure that they are marketing these products that they have? In what ways do they entice our mothers? What do they talk about when we are looking at how they interfere with breastfeeding? They exploit the parents' fears through misleading marketing for multi-billion-dollar businesses, and talking to a mother and alleviating her fears. Now my child will not grow well, or my child is not getting enough. And they tell the mother, if your child is not getting enough, you need to be able to add a formula onto that. And that will make sure the baby is full. So they work on the parents' fears, ensuring that they have talked to this mother. And once they express that, it means that that mother will definitely go and buy a breast milk substitute. They also look at the infant's behavior, for example, crying, poor sleep, which are misrepresented as medical problems needing formulas. And so we have different types of formulas that they have prepared. They will tell you this one is for a colic child, this one will make the children sleep well, if your child is crying for a particular reason, if your child has this particular type of allergy. Some are, you even wonder, there are very many of them. And right now they're being marketed everywhere. You look, you'll find a product that is talking about something or curing something or managing something. So that's how they talk to our mothers. The commercial milk formulas falsely marketed as improving sleep, brain development, they improved brain development and intelligence. These claims lack scientific evidence. Anytime you ask them for evidence to show that this actually happens, they don't have evidence for that. But they will tell the mother, your child will have a higher IQ if you give your baby a breast milk substitute. Your brain will develop well. In fact, they put very nice photos on those the tins or the containers that have the breast milk substitute. And if a mother is told that the sleep for the child will improve, why not take the formula? And so that is how they falsely market these products. Cross promotion or follow up or follow on and toddler milk builds brand loyalty and skirts advertising restrictions. You will find that the factories that manufacture or the marketers of this breast milk substitute have products that are also related to the child. So you will see a Pampers, a company that sells Pampers will also be the one that is selling the breast milk substitute. So what do? They tell you if you buy the Pampers or if you buy the formula, we'll be able to give you a box of Pampers. Most mothers will pick that because the price of the Pampers is also very high. So we also have brand ambassadors within the country, and Kenya is really taking up on this brand ambassadorship for the different products. We have people who are selling, even on billboards. You wake up and find a billboard that is put up that is selling one item using a Kenyan person who we all know as their brand ambassador. So we have the different cross promotions for the different items or the different companies that sell this. We also have Breast Milk Act violations that are very rampant and they're rarely penalized. When you walk on the road and see those billboards, when you look at TikTok, when you look at our Instagram, Facebook, and you find every person is advertising, every other shop, every other pharmacy, even hospitals have taken up advertising for breast milk substitute, violating the BMS Act 2012 and its regulation 2021. Something needs to be done because this is how they are doing it. This is how they are predating our mothers. Even in the villages, you'll find them walking around and talking to our mothers and communities. Where there is a chama, you'll find somebody trying to talk about the breast milk substitute. And so something needs to be done to ensure that our mothers are not getting targeted by the manufacturers of commercial milk formulas. We all know that as they are marketing their breast milk substitute and designated products, that mothers are able to breastfeed. Mothers are able to breastfeed if given all the support they require. And the support, as we saw in the 4 recommendations, starts with you giving the mother adequate support within the health facility like Kenyatta, and even when they go home. A mother is always able and is always ready to breastfeed her child if given the support they require. So as they are marketing, we need to ensure that they are able to make the best possible choices through access to information that is free from commercial influences. The mothers also need support structures and mechanisms that will allow them to be able to breastfeed their children, and when they get back to work, to be able also to get those support structures that will support them, like the workplace support for breastfeeding mothers. Breast milk support, a breast milk substitute causes risks by not having breast milk protective qualities. So we need to ensure that we are not giving these mothers breast milk substitutes for their children. Give them adequate information, give them adequate knowledge, give them adequate support structures to be able to avoid being being marketed for this breast milk substitute. And so how do they get, in addition, what do they get marketed, or how do these people get access to them? These manufacturers of breast milk substitutes inappropriately, aggressively, and unethically market breast milk substitute. By the way, they are very aggressive. They want to enter everywhere. They want to visit everyone. This undermines our effort to improve breastfeeding. They will want to talk to everybody, especially healthcare workers. Give them branded pens, give them branded, what are they called, lab coats, give them branded notebooks, so that as you're passing, wanting to brand the hospital walls, so that as a mother is passing, they will always see, this is a breast milk substitute, and if a healthcare worker is wearing this one, then it means that it is the best product. So we have to see this aggressiveness. We need to act on it as a country and as KNH. This inappropriate, aggressive, and unethical marketing also negatively affect choice and abilities of mothers to breastfeed optimally, because these other things are coming in that are negative, and they definitely influence their choice. Because let's give an example of the young mothers who are giving birth. And one of their branch of the people they call the social media activists, or the social media people, they give birth today, 2 weeks later, the person is doing a major event. She just gave birth and she's doing a major event. Her tummy is flat, she's not breastfeeding, and she's not within her home area. She's going to other areas, even going all the way. If they're in Nairobi, you'll find the person has an activity in Mombasa. They will carry the baby or not carry the baby. That means the baby will be given a breast milk substitute, any of them, given the numbers. And so that negatively affects the choice for our mothers. And when you listen to the young ones, they'll tell you, why do I need to breastfeed? If every other person is giving their baby formula, why should I? So their choice is affected at that. The marketers of breast milk substitute give us a total global infant formula market valued at around 70.98 US dollars in billions in 2022. It was expected by that particular research to increase to 1.53.26 billion USD by 2030. We're in 2025, and we have seen our use of breast milk substitute in Kenya has even gone high. So imagine how much it will be if you're using bottles and tea, as our data shows from our KDHS 2022. Where are we at? We need to be able to mitigate that. That's still data talking. So we have several challenges to achieving exclusive breastfeeding for 6 months and continued breastfeeding with the introduction of complementary feeding for 2 years or beyond. And what are these challenges that we have had? The first one is gender inequalities, where we have many working women lacking adequate maternity protection, especially in the informal sector, where they cannot afford to get away and get the 3 months maternity leave. They have to get to work immediately. Within 1 month, you're back to work. You have to leave your child working long hours, between most work between 8 to 12 hours. They cannot be able to get less hours of working. They cannot be able to get flexi hours. They cannot carry their babies to work, especially the ones who work in factories, in companies, in homes. Because some of us work in shops. You have employed a lady who just gave birth. Now she needs to be able to get some work off, and the place is busy. Supermarkets, some of the really, really basic jobs that our women do that are very great, but they cannot be able to get flexi hours. They work at least minimum 8 hours, 12 hours or more. And that really brings about gender inequalities for these women. They try. For some, the minute you take a maternity leave, somebody has to take over your place, meaning that for that particular month that you're not working, that you have gone to deliver, you will not get a salary because somebody else has already taken your place. And you're not sure even that you'll be able to get back to that workstation once you're finished with breastfeeding your baby in the next 2 to 3 months for you to get back. That is also stressful, and we know stress is one of the factors that inhibit milk production. So we really have it hard as women, the gender issues, and that's why we need support from the male counterparts to be able to ensure that our women are getting it right. For a mother who has gone to deliver, there could be support from the male counterparts within where she is, either at work or at home, to protect this mother from all angles. The other challenge is that we have misleading advertisements from commercial milk formula companies, which exploit the emotions, aspiration of the mothers, and they use pseudoscience to boost their sale, undermining health and the rights of the women and children. So those and there are very many. You go into a supermarket, you see them with children who are looking chubby. But nowadays the regulation are trying to ensure that that is actually not the case. The other challenge we have is influence on health sector. The commercial milk formula industry fund and influence health professionals, researchers, and academic institutions to promote their products. They will always want to fund somebody for their PhD, for their masters, for their college. They will want to conduct the people to conduct research for them. Some are ongoing that look into the formula issues, the milk formula issues. The academic institutions, some can get grants and funds, so if at all they are able to put forward their case for the milk, the breast milk substitute. That's a real challenge. They want to give things, pens, biros, their tools for work. They'll even buy a machine. They'll buy a water dispenser, a microwave. They can even be able, they are the ones who now sometimes want to be able to equip the lactation room in particular institution. Those are the influence on the health sector. We also have socioeconomic inequality and neocolonial wealth extraction, whereby 97% of all commercial milk formulas industry shareholders, shareholder value is owned by the high-income countries. None of them is located within the low-income countries, while the ones in the low-income countries are the ones who bear the harm from the marketing and the use of this breast milk substitute. There's an inequality there, socially and everything. The other challenges, we have commercial interests. The CMF rapidly expanding and regulated. These are multi-billion-dollar industry. Most of them are not regulated. When you look at them, some of them have, say, they are ISO certified, and most of the other regulatory, their cows they are well bred and all that. But looking at it, it is explained that most of them, they just make sure that the milk is there. They are producing and they are producing for the money, mainly, and they make a lot of billions from this. Major CMF and dairy exporting countries oppose international regulatory efforts on CMF marketing. They don't want to follow the code of marketing of breast milk substitute. And we have the International Code of Marketing of Breast Milk Substitute. Most of them want to be able to defy that. They want to go against it and sell their product to our mothers to feed to their babies, especially in low-income countries. Other challenges that are there, we have inadequate enforcement of the Health Act and the BMS Act 2012. I said we have, Kenya has also made the regulations for the Act 2012, which were done in 2021, to see if you can be able to enforce this BMS Act, because ideally it has not been enforced within the country. The other challenges are inadequate continued support for continuum of care after discharge from maternity. Kenya as a whole is trying to ensure that once the mother is discharged from the health facility, we use the community strategy where we have number one for care, that is the community taking over. The community health supporters or the community health promoters that were put up by the government or who are recruited by the government. Once the mother is discharged from a health facility, the health promoters are able to follow up the mothers even from home, do even community visits. For breastfeeding, we call the baby-friendly community initiative, where the mother is followed up from the health facility all the way to their homestead with regular visits so that there is that continuum of care. And we have to ensure that by the time of discharge, a health facility like KNH is able to link the mother to a relevant community support for her to be followed up there and to ensure that she's following up. The other challenge, we have aggressive marketing of foods and alcoholic sugar-sweetened beverages to children. We have quite a number of them that the babies are being given, and in the market you'll find a whole shelf that has these foods for children, either below 6 months or the one above 6 months who are on complementary feeding. They're in sachets, they are in mixes, there are quite a number of them. So that's a challenge that we have. And the child will always go for that one that they see looking very beautiful at the market, even when the mother takes the child to the supermarket. So what are we doing as KNH? Our theme was prioritize breastfeeding by creating sustainable support system. We have already built our case. We have shown our challenges. So what is this that you're going to do as we enhance our World Breastfeeding Week 2025? We have said we will focus on environment and climate change, going with the theme for the year. We're going to highlight roles in supporting breastfeeding to create a sustainable environment while reducing the impact of climate change caused by artificial feeding. We say unless a child requires an artificial feed or breast milk substitute, medically indicated, that's the only time. So on KNH, breastfeeding is our key. The theme is aligned with thematic area number 3 of World Breastfeeding Week, in aligning with the SDGs 2030 campaign. It will connect actors across all levels. We have the national, KNH is a national hospital. We have a healthcare system, workplaces, and we're going to link our mothers to the communities. The goal is to build a baby-friendly environment through coordinated and connected actions, which we have named above, and our synergistic efforts to support parents effectively at all levels of care within our hospital. Just looking as ways that we can be able to create sustainable support system. Just going back briefly, in 2023, the global exclusive breastfeeding rate at 6 months was at 48%, close to the target for 2025, which was 50%. You can see Kenya is slightly just above that. We are at 60%. So we're just looking at where we were and where we are as a country. To ensure positive growth and reach the new 2030 targets of 70% exclusive breastfeeding at 6 months, participation of each actor that makes up the warm chain is crucial. Kenya, we are at 60% currently. Can we make it to 70% by 2030? KNH is aiming to be able to help or to be able to galvanize for Kenya to be able to get to that point by ensuring those who pass by us are able to get all the support that they require. Supporting breastfeeding for a healthier planet requires creating a sustainable environment where breastfeeding is prioritized as a norm. When breastfeeding is protected, promoted, and supported, a sustainable environment is created and will help us to mitigate immediate impacts of climate change. So we have to be able to promote, protect, and support breastfeeding in line with the 17 SDGs to be able to alleviate any inequalities in relation to breastfeeding. So what is our role as a health facility? and the healthcare workers within our line. That means KNH. We need to be able to implement the 10 steps to successful breastfeeding. I'm going to outline them briefly, what they are. We need to invest in hospital-based breastfeeding support by training all health workers that take care of mothers and babies on breastfeeding. Currently, we do 2 trainings for maternal, infant, and young child nutrition. We have 2 trainings per year, and we intend to be able to add an additional one for baby-friendly hospital initiative, which we'll be able to include for this year. We'll have a few classes for that to ensure that every health worker that comes within those units is able to get the adequate training. KNH is complying with the BMS Act 2012. We try to monitor and report the violations that come our way, and we are going to sustain that. KNH will educate mothers and families on environmental and health benefits of breastfeeding versus formula feeding. We do this as a norm, and for this particular time, we will be able to ensure that it continues, because it starts all the way from the antenatal clinic to labor ward to the postnatal wards, and for the children who come in later with the various medical conditions or indications, we are able to ensure that we educate our mothers on the benefits of breastfeeding. KNH protects breastfeeding in emergencies and climate-related disasters, ensuring safe spaces for mothers and babies. In case any appears and there's a disaster, KNH is always ready to be able to handle the emergencies for mothers and babies. And if for whatever reason the mother and the baby is separated, we are also able to help them or to be able to give them support until the mother and baby is reunited with their baby to continue breastfeeding. KNH supports women through individualized breastfeeding counseling from pregnancy to postnatal follow-ups, and we also do community linkages. We participate in community dialogues with our communities that surround us and conversations, especially at the Well Mother Clinic. We have health promotion campaigns within the hospital on sustainable breastfeeding. So as KNH, I can say from the nutrition department, in collaboration with all the other departments, we are able to support, promote, and protect breastfeeding. And as I summarize, we are going to look at the 10 steps that KNH has adapted to be able to support, promote, and protect breastfeeding and make KNH baby friendly. We recently did a baseline survey to this 10 steps to successful breastfeeding to look at where we are at as KNH, to be able to see where do we need to go and which of the particular steps are we not up to par, because we are supposed to get at 80% of each of these steps that I'm going to outline. There are 10. Some of them we are at par, some of them we are not at par, some of them we are very low, but that is why we did a baseline to look at ourselves, internalize where we are, and see where do we need to improve, where do we need to put effort to be able to prioritize breastfeeding and be able to create a sustainable environment for our mothers and children. So step number one has 3 steps in it. The first one, 1A, it says complying fully with the BMS Act 2012 and its regulations. KNH complies to that. Step 1B, have a written infant feeding policy that is routinely communicated to staff and parents. We have the National Infant and Feeding, Maternal Infant and Young Child Policy. We are yet to prepare the KNH policy, but we are underway. It's already in draft. We'll be able to actualize in the next coming few months. Step 1C, establish ongoing monitoring and data management system for all our mothers who are seen from the clinic, the antenatal clinic, ongoing. We are able to have data for them. There are some gaps in the data monitoring system, which we are going to rectify as we go along in the next few months to enable us to capture the data as required. From the staff who are trained to the clients that we receive, we need to have their data. So that's step 1C. Step 2, ensure that staff have sufficient knowledge, competence, and skills to support breastfeeding. As I said before, we have 2 trainings that are class-based for maternal, infant, and young child feeding. We have the BFHI that is coming, the Baby Friendly Hospital Initiative, for this 10th step that is coming. We also usually have the continuous nutrition education sessions that run within the year, and those are able to give us the knowledge. And we are going to continue ensuring that we give knowledge either through the webinars or through the continuous nutrition education within the health facility and wherever we are in our different workstations. Step number 3, discuss the importance and management of breastfeeding with pregnant women and their families. That happens at the antenatal clinic and even in the wards for the mothers who have been admitted for various reasons, medical indications, and they have not delivered. That information is passed to them. Step number 4, facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. That happens in our labor ward, and we are able to say that for most of the mothers who deliver here, we are able to articulate step number 4. Step number 5, support mothers to initiate and maintain breastfeeding and manage common breastfeeding difficulties. That happens in our postnatal wards and in the maternal mother when baby clinic. We are able to handle all the issues that they have so that our mothers can be able to maintain lactation. Step number 6, do not provide breastfed newborns any food or fluids other than breast milk unless medically indicated. That one we comply to, and we're able to have data. We can be able to see from our files, unless it is medically indicated, we do not give our children who are born here, our newborns, any foods or fluids breast milk. Step number 7, enable mothers and their infants to remain together and to practice rooming in 24 hours a day. Yes, for this one, KNH is fully compliant. All our mothers stay with their babies right from birth all the way up to the time of discharge. Unless it is indicated that the baby needs to go to the newborn unit if they have particular issues, but even when they are in the newborn units requiring ventilation or other care, the mothers always visit them every 3 hours. So for this one, KNH is fully compliant. Step number 8, support mothers to recognize and respond to their infants' cues for feeding. We teach this to all mothers from ANC all the way to the mothers in the ward and by the time they are getting discharged. Step number 9, counsel mothers on the risk of feeding bottles, teeth, and pacifiers. This one we talk about when the mothers are in ANC in all the whole spectrum of care. We talk about this and we counsel mothers on the risk of using them. Step number 10, we coordinate discharge so that parents and their infants have timely access to ongoing support and care. So at the time of discharge, our mothers are directed, if they're able to come back to KNH, they come back here within the stipulated time that they should come. The first one is after 2 weeks for the mother, after 6 weeks for the baby, and we continue with all the care up to the time the child is 2 years. If we are not able to follow the child and the mother within our facility, we usually because most of our clients are referral, we usually prefer to send them back to their particular health facility where they come from and their community where they come from. So we give referrals on the discharge summary. We give them referrals to the area that they come from to their particular health facilities. So that one, we are compliant. So those are the 10 steps to make our hospital baby friendly. Where we are behind, we are going to pull up our socks and ensure that we comply to the 10 step. And it's our prayer that we'll be able to be designated as baby friendly within the next coming few months, as it is indicated by the Ministry of Health. And we are going to follow up on that. Yes, the team is very enthusiastic to be able to achieve that. As nutrition department, our goal is to achieve that, and the team that is mandated with this activity is usually very enthusiastic and is trying all they can to be able to achieve this in line with that. And that's why it has been coordinating for this week of World Breastfeeding Week to ensure that we create these sustainable activities. Thank you.
Thank you so much, Virginia, for an extensively elaboration on this theme, prioritizing breastfeeding by creating sustainable support system. This is this year's theme, and it runs from started on 1st until the 7th. That's now the end of the campaign, and this year's theme underscores the need for investment, and system building to support breastfeeding so that it benefits us all as a public healthcare providers, and also to provide equity, and also for the sustainability of the environment. The goal is sustainable change across healthcare system, government policy, workplace norm, and community support network. So briefly, we will be looking and answering on your questions that you have posted on our chat box, and maybe we can answer from Jerry. He tells us, what's your take on pacifiers? What's your take on pacifiers?
My take on pacifiers, no child should be given a pacifier. The reason being, they have they cause various issues on the child. Number one is poor dentition. A child with poor dentition, it will inhibit or it will prevent the child from breastfeeding regularly because number one, the mother will not be able to see a hunger cue. The mother will not be able to know when the child is ready to breastfeed. Again, the child who has breastfed, they have been almost sucking on that pacifier. So what happens? When the time it comes to breastfeed the child now will not be able to breastfeed. The cheeks are tired, the muscles on the whole mouth area is actually tired. So a pacifier should not be given to any child because it will interfere with the whole lactation process.
Thank you so much. Someone wants a clarification, maybe that's Wanyama will take us on that, about when should we start complementary feeding, though we are not on that, but maybe you can just clarify about complementary. When do we start complementary feeding?
Thank you for that question. What an interactive session that we had. We always say that you're supposed to start complementary feed after 6 months, first 6 months. There's that confusion that when do we start? Is it upon reaching 6 months or on completion of 6 months? So the idea here is you can count 180 days after birth, and then you start on 181st day for complementary feeds.
Thank you. Someone say, what's colic? Colic is a condition seen in a healthy infants that is characterized by frequent and prolonged intense crying, which is confused with fastness without any obvious cause. From Anonymous, that's what's homogenization? What's homogenization? Maybe I can take on that. And homogenization is a method of food preservation where the milk and other liquids form a uniform and stable debris. This is actually making a uniform solution by breaking the fat molecules into a uniform to form an homogeneous solution. And that's why you see a milk, there is that whole milk contained fat that is being broken down through a process we call it perfusion process. So it's a method of food preservation. As opposed to maybe pasteurization, it's actually breaking fat down and also improving texture, and it's actually a mechanical process as opposed to the other pasteurization. From anonymous attendee, they are asking when or advise mothers who are seropositive about breastfeeding, and elaborate about a first criteria. So maybe Jack.
The mothers who are exposed, that are exposed, we usually do a thorough history taking, do some tests that will be able for us to make an intervention. And here we usually discourage anything like mixed feeding. So we'll take the mother through counseling and discuss the advantages and disadvantages of choosing either. So the idea here is you have to choose one. If it is breastfeeding for the first few months, 6 months before introducing the complementary, or if you're going for other alternatives. But this one you have to go through thorough counseling so that for you to understand the decisions that you're making. So we don't encourage mixed feeding when it comes to several exposed.
Thank you. And maybe a FAST criteria, a FAST is an acronym that stands for acceptable. That means the food that you are giving the child should be culturally or social barriers to be used, should be acceptable by the family, the normal food that you are taking. F stand for feasible, affordable, available, sustainable, and safe for the child. Yeah. Thank you so much for that feedback. Yeah, they are saying the presenter is well knowledgeable, fast. She's saying that you participated in formulating this theme, so thank you for that adding up our presentation. So from anonymous attendee again, he wants clarification on rooming in, difference between rooming in and kangaroo mother care.
Okay. Rooming in. Rooming in is where the mother and the baby stay together, if possible, on the same bed after birth and continuously after that, and which is recommended. All mothers and their babies should remain together after birth on the same room or in the same bed, if possible. Kangaroo mother care is where, and nowadays we even have the fathers doing kangaroo, is where we have the low birth weights. The low birth weights or preterms usually require extra warmth. As they're being taken care of, they have to remain on the mother's chest, skin to skin, for considerable amount of time as they gain their weight back, or as they get to the, because they are low birth weight or others who are born preterm, they require to have the mother's warmth. So they are usually kept close to the mother, and they are tied. There's a way we tie the baby on the mother's chest, ensuring that the baby is not suffocating in there. They stay in a special room that is warm, called a kangaroo room. Yes. It is for purposes of ensuring that the baby is being taken care of until they achieve a time that they can be discharged from the hospital. It can continue at home, but mainly it's done in the medical setup, in the hospital setup.
Maybe to add on that, I like the way some culture, they practice rooming in. You'll find that once a baby is born, the mother and the child are like put in a room locked for a month, and here every other services the baby or the mother needs, they're able to be provided. And that really works magic, because you'll find that now, after that period of 1 month, there's a lot of progress in terms of growth and development in terms of both the mother and the child. Others, like in a hospital setup here, we also do bedding in, which is almost similar to rooming in, but now it is there. Just like Virginia was saying, now the mother and the baby are put in the same bed, and then they for them to, for a period of time. Thank you.
Thank you so much. How does stress inhibit lactation? I can say stress can inhibit lactation by interfering with the hormones pathway that are essential for production and release of hormones. Some of these hormones are prolactin. We have also oxytocin. Those are some of the hormones that causes stress and inhibit milk production.
And maybe to add on the prolactin, we find that we encourage the mothers to have a night meal or a snack because during this period, we find that prolactin is more at night, and it helps in the production of milk as opposed to during the day. So that idea of also introducing a meal at night, as per the baby friendly hospital initiative also state, we encourage that. Thank you.
Thank you. Anonymous attendee asked on breastfeeding post CS. What is the recommended time period before a mother is put on lateral position for breastfeeding?
On breast
Anonymous attendee on breastfeeding post cesarean. What's the recommended time period before a mother is put in a lateral position for breastfeeding?
Unless she gets to a comfortable time, because remember we have a wound, a cesarean wound, there is a cut. So unless she's able to, until a point where she's comfortable, because most of the time the mother is lying on the side. Yes. We have the lying position for breastfeeding post-cesarean. Yes.
And when you're talking about initiating breastfeeding, we usually say that within the first 5 minutes to 60 minutes, that is when the initiation should start. The challenge only comes when now we have the surgical procedures that are done. But usually we find that the baby is put on before even cleaning the amniotic fluid, the baby will start moving forward, looking for breath.
Thank you, Jack. Akinyi Awino says awesome presentation. Thank you. Madam Marentho Edna say wow, quite an eloquent presenter with master nutrition knowledge in regards to breastfeeding. Excellent flow of information and very well organized. Indeed, I have updated my knowledge on matters breastfeeding. Bravo, Virginia. Bravo, Virginia. That was very professionally done. Keep it up. The same spirit and good work. Thank you, Madam Marintha. From anonymous attendee, what are the national challenges in implementing explosive breastfeeding? National challenges. I think number one is inadequate training of healthcare workers. We have also weak baby-friendly hospital initiatives in terms of implementation in various setups. Poor postnatal follow-ups. This is seen where a mother is delivering in hospital A and being discharged into this county. Those are some of the challenges. We have also socio-cultural beliefs and practices. We have aggressive formula marketing, as presenter had said. Workplace and economic barriers. Those are some of aspects that it's play a role. Policy and political will. We need to have political willingness to help us move this mile. We have also kind of lack of public awareness and education in terms of what they should do, existence of workplace support, existence of some public policies. It's actually a point of knowledge. Anchor. That's some of the challenges. Maybe Jack Wanyama, you can add.
I've said most of it.
Thank you.
But usually we find the challenges are there and they are real. as a nation, we have very nice policies, but now to implement them is a problem. So there's that gap. Either it's because of the funding, or it's just issues that are related to hospital setup.
Okay. From John say, what are the nutrients that promote brain cell development? Brain cell development. Some of them are omega-3 fatty acids. We have protein, that's amino acid, iron. We have also zinc, choline, folic acid, pyridoxine, which is B6, cyanocobalamin. We have iodine, vitamin D,
Just
and
the IFAS.
vitamin A.
Just the IFAS.
The IFAS, yeah.
They really play a role when it comes to brain development. Remember, within the first trimester, that is when the fetal organs start forming. And that is the best time to also introduce supplementation in terms of IFAS. All these supplementation, they work to correct all those congenital issues that may come on. And most of them, they usually affect the brain.
Okay. Thank you, Henry, for adding on our presentation about pacifiers, that they cause dental caries. They reduce the saliva, which contain lysosomes that protect the inner epithelial tissues. Thank you so much. So maybe you can tackle one of the question here from anonymous attendee saying, what does stress inhibit lactation? I think most of the questions we have tackled, and maybe the last one is prolactin. What's hormone prolactin?
We mentioned that for now.
Oh, we have tackled it. It's primarily involved in regulation of lactation, that is lactogenesis. Lactogenesis, while we have galactopoiesis, that is to maintain milk production. Thank you so much for your looking in and also your attendance. Seeing you next time. Thank you.
I wanted to finish the partnership. It's okay.